Chalo. So today we will discussing with you on the pain management, acute. Remember last class we discussed with you on the chronic pain management and then the pain assessment. First I did pain assessment, then I did chronic pain management. Today we'll talk about acute pain management. Okay, there is a lot of difference between chronic pain and acute pain. So what is, you've already known definition of pain. Pain is defined by the International Society of Study of Pain as unpleasant sensory and emotional experience. See, sensory and emotional experience, because you express the feelings there when the pain comes in, and sensories are also tickled. So sensory and emotional experience arising from actual or potential tissue damage, so described in terms of such damage. So any damage leads to pain. So pain is generally, it is not a generalized, it is highly personal, subjective experience, which can only be accurately described by the individual who is experiencing the pain. If Delvin is experiencing the pain, then somebody else do not understand what is the magnitude of the pain Delvin is going through. Or if, say for example, if Rebecca is feeling the pain, she only knows, and two people may not have the same intensity of the pain because it is their personal experience. Okay, chalo. So acute pain. Acute pain is normal, predicted physiological response to adverse chemical. Say some kind of a chemical substance which is hurting, or thermal, that means the heat, or mechanical stimuli associated with surgery or trauma or acute illness. Okay, so acute pain is an indicator. Many times it is a warning signal that something has gone wrong, and so we need further examination. Just like the way when person is feeling feverish, then check up what's going wrong. If person is feeling pain, then also we need to say check up what's going wrong. So acute pain is typically self-limited and resolves over 1 day to some weeks. But sometimes if it is not managed well, it can persist for 3 months or even longer as healing occurs. Okay, so this acute pain can activate sympathetic branch of autonomic nervous system, and as a result, acute pain can lead to blood pressure, that means hypertension. Acute pain can lead to cardiac tachycardia, or it can reduce, it can cause respiratory illness or restlessness, that is emotional mental illness. Or we can see in a body language facial grimming or guarding behavior, pallor, or pupil dilatation. So what I'm saying is pain can be experienced, can be seen by means of a body language. Okay, or it can be so varied. So one need to understand what is going on. Okay, so inadequate relief of pain can contribute to hypercoagulability and impaired immunity, leading to complications as venous thromboembolisms or infections. So that is why, as I said sometimes back, pain is an indicator. So if there's a leg pain, find out what's happening. There may be an infection. If you don't handle the infection, that may lead to some, or you might hit something that if you don't handle that, then it may lead to venous thromboembolism, which may be complicated. So inadequately controlled acute pain can be a factor in the development of chronic pain. That is why it is said, stitch in time saves nine. Okay, so extended hospital stay, or in fact patient dissatisfaction, etc. So pain is a very important factor for a comfort, and it shows many things. So pain is often classified by its pathophysiology into nociceptive pain and neuropathic pain. Okay, nociceptive pain involves normal neural processing pain that occurs when free nerve endings are activated by tissue damage or inflammation. Okay, generally when the nerves are tickled or nerves are damaged, pain comes in. Whereas neuropathic pain involves abnormal processing of a stimuli from peripheral or central nervous system that is thought to serve no useful purposes. So I've told you two things. It can be nociceptive pain or neuropathic pain. So nociception involves four processes: transduction, transmission, perception, and modulation. So these are highly complex, but simple summary can aid understanding the pain mechanism, and it will give a direction for pain intervention. Okay, so first, when the tissue is damaged, then it releases enormous chemical substances. See, most of what happens in the body, there are mediators, neurohumoral transmitters, mediators like prostaglandins, bradykinin, serotonin, substance P, histamine. I think you've studied all these things in the pharmacology. We have autocoid chapter is there. We study all these things. You better go through. Also, very very interesting. So these all this the transmitters. So these substances can activate nociceptors, can then activate nociceptors, resulting in transduction or generation of an active potential, an electrical impulse. Okay, these ensure that an electrical impulse is generated. Then the second is transmission. See, the action potential moves from the site of injury along different afferent nerve fibers to nociceptors at the spinal cord. That is where the pain is felt. Okay, so these are the one which takes the nerve impulses, and then the substance P and other neurotransmitters carry action potential across the cleft to the dorsal horn of the spinal cord, from where ascends the spinothalamic tract to the thalamus and to the midbrain. You see, I'm talking about the way how all this transmission happens, which all happens in fraction of a second. And then thalamus, the fiber sends the nociceptive message to the somatosensory cortex, parietal lobe, frontal lobe, limbic system, where the third nociception process, that is perception, occurs. See, everything, it has to go to the brain, and there are certain sites are there for that. So it just travels through all those things to go over there. And then final process is modulation. Modulation is results from the activation of the midbrain. So it looks complex, but it happens in a fraction of a second, nanosecond to micro to nanosecond, fraction of a second. The whole thing speed is very, very fast. So multiple types of neurons from this area have variety of neurotransmitters. Listen, most of this action happens through the chemical substances, endorphins, enkephalins, serotonin, there is 5-HT, dynorphin. So these descend to lower areas of the central nervous system, and these neurons stimulate the release of additional neurotransmitters, which trigger the release of endogenous opioids and inhibit the transmission of pain impulses at the dorsal brain horn. So these enkephalins, endorphins, dynorphins, they are the pain antagonizers. They are the endogenous opioids. Morphine is an opioid, methadone is an opioid. They are the exogenous opioids. But whereas endorphins, enkephalins, and dynorphins are the endogenous, that means they are in the body, they are released, and they transmit, and they antagonize the pain. It's an amazing mechanism. Thank God for the complex system that is made so simple. Okay, so okay, now I just told you here the way how pain originates, pain ascends, pain descends. Okay. Now let's look at quickly the acute pain assessment. See, it is one thing is to assess a chronic pain because pain remains over a long period of time, pretty complex. Acute pain is a short pain. So it's very important to have accurate assessment of acute pain for the development of effective pain management plan. So as we saw, I think the first class I talked to you on this, patient self-report is very important. Self-report will tell you the sensory, emotional, psychological, cultural component of the pain, which cannot be captured by unidimensional tool typically in practice. And that is why a comprehensive pain assessment strategy will be there, which includes we need to know from where the pain is location, how is the quality of the pain, what are the aggravating factors, what are the alleviating factors, what is the timing and duration and pain relief, functional goals, intensity. All this complex has to be understood very clearly. For that we need a goal, and then assessment is important, then the effectiveness of the previous treatment as well as the effect of the pain on quality of life, that should be clearly understood. So only when you assess this, then you have started a strategy, then you say, how is the quality of life as a result of this strategy? Okay. So to determine the treatment effectiveness and plan the intervention, there are plain assessments. They focus on the nature of the pain and intensity of the pain and responses to the treatment. Okay. So pain assessment tools should be valid, reliable for the patient population to which they are being used. So there are various pain assessment scales are there. They're called as unidimensional pain intensity scales. So these are quick and easy to use. They provide rapid feedback about the effectiveness of the intervention and are valid and reliable measures of pain intensity. Because the unidimensional scale measures only intensity, they cannot substitute the comprehensive pain assessment, but it definitely will tell us the clinical setting. We will tell us how is the origin of the pain. There are many unidimensional pain scales, numeric scales, visual scales, verbal, descriptor scales. So numeral scales, this is a numeral scale is used graphically. So numeral scale consists of vertical or horizontal line that anchored. We generally say, no, what is your weave? How is your pain? In 0 to 10. In a scale of 0 to 10, how is your pain? So patients are instructed to rate the intensity of their pain on a 0 to 10 scales. Okay, that 10 will be the worst, 0, no pain. So that is a numeric rating scale. But whereas visual analog scale, so visual analog scale is asking the patient to mark the intensity, as to mark visually a particular thing as to how much is the pain and how less is the pain. Distance is translated from the pain intensity score ranging from, again, it can be 0 to 10. Then verbal descriptor scales. That means no pain, mild pain, moderate pain, severe pain, very severe pain, worst pain possible. Okay. So we can ask all this, tell the patient, tell me how is your pain. Okay. So that is one kind of a scale. And but whereas sometimes to older adults, it is very difficult for us to assess their pain. And so in older adults, the mild to moderate impairment is not very comfortable to have a self-report of pain. So many unidimensional pain tools have been tested in older adults, and other than that, there are many, say, called as the face pain scale, or Iowa pain thermometers. These have been validated and they found it to be useful for this. There are other people who prefer verbal descriptor. See, because many times the elderly, especially the palliative care. They will be going through acute pain, but who will express the kind of the pain they're going through? So the assessment of pain in a population where behavior or vital sign provide sufficient information to assess the pain do not give indications of the pain assessment. Okay, so nurses often rely on the heart rate. It means they say if the pain is there, the heart rate will increase, or the respiration rate will increase, the blood pressure may increase, or other physiological data to confirm the presence of the pain. So that is an indirect way of assessing the pain. Especially for the senior citizens, these are very important. So they say uh, there are about 5 key steps are recommended in such a case where you do not know how to assess. Number one, they say when possible, often self-report. But if it is not possible, look for possible pathologies that or procedures or other causes of pain. So sometimes they say lift the leg, little bit of leg, little, even if you lift a particular height, if the person doesn't say pain or doesn't give a body language of pain, then you understand the intensity of the pain. Some of you, if you had senior citizens at home, a grandfather, grandmother, and you would have seen these things happening there. Okay, so observe the behavior, observe for behaviors that may indicate the presence of pain. What are the behavior? Sometimes when there's a pain, they become cranky. They start screaming around. They become so furious. Observe the behaviors. If there's no pain, they'll be quiet, they sleep off. Okay. Then obtain the input from the caretaker. Most of these senior citizens will have caretakers. So to know the patient and patient's unusual behavior, response to pain. They don't want to sleep in one position. Keep on turning because it is paining somewhere there. Okay, and they also have one more ways, that is use an analgesic trial. You have a pain, you take this analgesic, then they say, oh, I'm gone, I'm okay now. That means he had a pain. So there is a analgesic trial, they call various trial and error method which has to be standardized to assess the pain for senior citizens. Okay, now the first one, as I told you earlier, the self-report, which is the best one. The second one is assumption of pain. If a reliable self-report, then pain cannot be elicited. Next step is to consider whether the patient has a condition that is typically associated with pain, undergoing procedures that is generally painful. Third one, I said behavioral of pain. That means requires a nurse to observe indicators of pain, like grim faces, like facial expression, rocking, change in activities, change in the position of sleep. Okay, then the ask the caregiver, as I told you sometimes back. This is what we call it a surrogate, who knows patient's usual behavior. They say, no, he will never do like this. Now he is doing this because there's a pain. Okay, this is a very unique response to pain. Then the last ones I told you, analgesic trial. Okay, so this is all I told you about the assessment. So first one I told you, definition of this acute pain, and then the next I came to you. Next we discussed about the assessment. Now we'll get into treatment strategy. Okay, this is my last topic in this acute pain. So pain relief can be achieved by pharmacologic and non-pharmacologic measures. See, most of the time when you go back from college, you will say, I have a headache. You will generally not take tablet. You'll say, I'll just go sleep for some time. That is a non-pharmacologic measures. But whereas you say, I'll have a paracetamol in my purse, let me swallow a paracetamol, that's a pharmacological strategy. Okay, so now pain medications can be divided into 3 categories. I'm sure you've studied this in pharmacology. One is opioid analgesics, which is very strong, and whatever acute pain is there, tuck, it will go opioid analgesics. Then non-opioid analgesics, all this NSAIDs. Then co-analgesics. I'll come to you about co-analgesics after some time. I'll explain you all this, the co-analgesics, these antidepressants, and local anesthetics. Okay, so first one we'll look at non-opioid analgesics. These are NSAIDs, non-steroidal anti-inflammatory drugs. All your paracetamol, commonly you take paracetamol, no? And now you don't take aspirin. Aspirin also is restricted to use, but paracetamol is commonly used. So NSAID medications exert their analgesic effect by interfering with the inflammatory response. You're familiar with that. So they especially useful when the pain is by surgery or infection or trauma or exertion. Generally, NSAIDs, they inhibit the cyclooxygenase enzyme, that is a COX, and reduces the synthesis of prostaglandins. Okay, you're familiar with that. So you look at this page, look at this graphic. So pain, this central nervous system pain. So we use opioids, centrally acting analgesic, there's acetaminophen, then anti-inflammatory agents we act for central pain. But whereas there is ascending input or descending input, when it comes to here, the dorsal horn, here these are sometimes the local analgesics can be very useful here, anesthetize the whole thing, take away the pain. Opioids also will be very useful here. Then NMDA antagonists are very useful here. These are all the central nervous system. Then you can also have, for this nerve fiber can be anesthetized by local anesthetic and reduce the pain. And then you have a trauma, which is peripheral neuroceptors, nociceptors, which is not in the central nervous system. For this, you need anti-inflammatory agents or COX-2 inhibitors. This can be very useful over here. Okay, this I just thought of giving you. When you talk about the drugs, you need to know that the various drugs can be used like this. Now we are talking about NSAIDs. So there are many newer NSAIDs are there. I have only 10 more minutes, okay? I'll try to cover it as early as possible. Newer NSAIDs, the COX-2 agents are there, but because of the limitations of COX-1, then COX-2 are brought in, but fewer untoward effects occur in COX-2, selective other than the NSAIDs, but COX-2 have its own disadvantages. They're not safer for kidneys, and then their response to earlier anti-inflammatory agents is highly individual. And if one NSAID does not work for patient, there are always others. So you need not be very restrictive. So remember, there is a toxicity level is there. For example, you cannot give aspirin kind of a drugs to GI ulceration. You cannot give paracetamol kind of a drugs to alcoholics or to liver problem patients. So you have to be very cautious. You cannot give COX-2 agents for the nephrotic patients, kidney problem. So you have to look at what are the challenges, and then accordingly drug has to be selected. Okay, so now opioid, very powerful analgesics. So opioid analgesics act by binding to and activating specific receptor sites in the central and peripheral nervous system. Morphine, fentanyl, hydromorphinone, oxycodone, these are mu receptor antagonists. Okay, these are mu receptor antagonists, and the very common side effects of this, again, as you know, is nausea, vomiting, pruritus, sedation, and most dangerous is respiratory depression because they suppress the respiration. So you need to study an amazing chapter on morphine to know the advantages and disadvantages of morphine. Okay, and so I was talking to you sometimes back about co-analgesics. So first we talked about the NSAIDs. Second, that is non-morphine. Next, we talk about morphine. Third, we're talking about co-analgesics or adjuvant analgesics. See, these co-analgesics are diverse group of medications that enhance the effect of typical analgesic medications or provide analgesia for certain type of pain. For example, local anesthetic. What will do? This will just anesthetize. Local anesthetics, muscle relaxants, certain anticonvulsants are used as a co-analgesics. Local anesthetics like your xylocaine, repuocane, bupivacaine, they block the sodium channels and in the nerves and prevent conduction of the nerve impulses. So if there's any nerve that is responsible for this, apply local analgesic over there. So it is decreases the pain because it causes numbness over there. It just analgesis or anesthetizes that particular nerve locally. Okay, so it is actually not analgesic, but analgesia is a subsequent property of the anesthetic, local anesthetic. But it has its own adverse reactions, sensory, motor deficit, neurological, mental status may significantly signify the systemic toxicity from increased blood levels of medication. It may cause dizziness, confusion, metallic taste, seizures. There can be cardiovascular problems like hypertension. Sometimes it may lead to cardiovascular collapse. So need to be very cautiously observed. Remember, this is not an analgesics, okay, but can be used. Next is muscle relaxant. Remember, when you are playing a game, you have a pain, then you use that, what is that, Iodex. Iodex has, what is that muscle relaxant? Methyl salicylate, that aromatic substance, methyl salicylate. So it has, and even many others on this, the external stimuli, external local applications have these muscle relaxant. So skeletal muscle relaxants derive from several different drug classes, including benzodiazepines, antihistaminics, sedatives. They are not considered as effective analgesics. Benzodiazepine are analgesics only for pain associated with muscular spasm. Okay, they are not analgesic as such. So mechanism of action vary and are non-specific. So these should never be used as analgesic, but they are the adjuvant analgesic. These medications are associated with diverse effects of sedation. The problem with this is the respiratory depression. The risk of respiratory depression is increased. The risk for respiratory depression is increased in patients receiving concurrent muscle relaxants and opioid medication. See, the skeletal muscle relaxants have respiratory, they depress the respiration, and opioids also depress the respiration. There is a cumulative depression of respiration if both of them are taken together. And that is why, as a clinical pharmacist, you need to be very aware, observant, and look at things very carefully, not just theoretically, but practically in a patient. Is the patient experiencing that? Sometimes it may go on oversight for a doctor, and you people have to be there to help them to make sure system is pakka in place. Okay. Now, anticonvulsants. Anticonvulsants, they are also used primarily to treat the persistent neuropathic pain, especially stabbing, shooting, or electric-like quality of the pain. Because remember, they also are a CNS drugs, but their mechanism is entirely different. So, gabapentin, pregabalin, these are used in the preoperative period, and gabapentin is generally used in acute burns. So anticonvulsants act by stabilizing the nerve membrane, reducing the excitability, and reducing the spontaneous neuronal firing. In fact, that is what its mechanism as an anticonvulsant. They may have a role in the prevention of persistent post-surgical pain syndromes. So that's how it is. The anticonvulsants can also be sedating. See this. What are the barbiturates. They're powerful sedators. Caution is required when they're administered along with morphine medications, because morphine are also sedators. Okay, now this is my last topic, non-pharmacologic treatment of pain. As I told you sometimes back, there are n number of non-pharmacological treatments out there. For example, you say you want to sleep, or you let somebody massage your head here, or there is a pain over there, you say massage that particular point, or take that skeletal muscle relaxant, massage that particular thing. Okay, so there are various, some people's pain will go by listening to some nice music. Okay, so they involve physical modalities like acupuncture, massage, positioning, deep breathing, application of heat or cold, or psychosocial modalities like distraction, biofeedback, imagery, etc. It all is very specific. I mean, it depends upon individuals. Okay, I think this is my last, and I have completed the pain and look into all these things. Now, as I told you sometimes back, Delvin, this is your assignment. Ask all of your friends to let me know what are the top questions that you find it difficult to answer from the old question banks, old question papers. Now, I've
Okay,
sent
sir.
you all, yeah, I have sent you all a question bank. Remember, university will definitely not follow that. We have made a rule in the university never to follow their question bank, but question bank is a guide to all of you. Okay, so use that as a marker, as a guide, but never depend on that for the question paper. Okay, so follow this. Anything is there, come back to me, then accordingly I'll prepare some questions, some classes depending upon the doubts that you have, and schedule the class. Is that okay? Okay, Delvin, you send me the attendance. I'm almost done in the next few seconds.